Well, thank you very much. Thank you very much, Andree, to invite me to be here. It's a very big honor for me to speak to you about our approach in correcting difficult cases. We heard this a little bit in the morning session. It's difficult when you have problems after breast-conserving therapy to treat these patients because they need something more than just leave them at home with asymmetry of the breast or not a nice breast. So in our service in Düsseldorf, we are focusing on autologous reconstruction with perforator flaps, mainly DIEP-flaps. And I would like to show you some of our experiences in correcting bad breast cancer conservative treatment. So we all know, and we heard yesterday, that breast-conserving therapy is combined with radiotherapy, still the standard treatment for primary breast cancer. And it has some benefits since we use oncoplastic surgery. We have surgical benefits, financial benefits, and psychological benefits because the patient is not losing her breast. And doing that, it showed in Europe that we have to have a breast cancer team together with the oncologist, the plastic surgeon, the radiotherapist, and the oncologist surgeon to treat the patients in one team, because you have to find out something about the tumor, and then you have to find out if you have to make an axilla dissection. Then you need to have guideline treatments, as we heard this morning, and then we have to find the best surgical treatment for the patient, either breast-conserving treatment or mastectomy or skin-sparing mastectomy. And then we should decide what kind of reconstruction we use, either implant-based, as we heard, or autologous reconstruction. And this is an example of a patient who has breast cancer on both sides, and we need to figure out where the tumor lies, and we need to find out where the tumor is on the skin or on the pectoral muscle, and then we will find the best surgical solution for this patient, being oncologically safe and have a good aesthetic result. As you see here, this patient has a latissimus dorsi flap on the right side and breast-conserving therapy on the left side. But as we know that more than 70% of breast cancers be treated with breast-conserving therapy, and we see problems according to this. We have a local recurrence rate between 9 and 14% of the breast, and we have sometimes problems of the extent of local excision. And then we should always have in mind the ratio between the breast and the tumor size, and then the tumor location. Even if it's on the medial part, it's more difficult to correct than on the lateral part. And we also have to see the long term of radiotherapy, what we do after breast-conserving therapy, and then the cosmetic result. And as we know, breast surgery starts as reconstructive, and then we should try to give the patient the best result we could even achieve. And the risk for deformity is actually poor surgical planning and hematoma, infection, necrosis, scarring, and retraction, as we all saw in the morning session. And the cosmetic failure after breast-conserving therapy is up to 50% when you do poor planning and when you don't do oncoplastic surgery. Although there's a classification of defects after breast-conserving therapy from Clough in 1998, and we have 3 types. Type 1 is asymmetry without contour abnormality, so it's asymmetry on the right side compared to the left side. And then we have the type 2 is asymmetry with contour abnormality, and then type 3 is severe asymmetry requiring delayed reconstruction. And if you try to correct it with type 1, you just do contralateral surgery, in order to have symmetry. And in type 2, you have to reconstruct the breast to get symmetry. And in type 3, you have to have a whole breast reconstruction, mainly using autologous tissue. So what can we do? What are our options to correct breast-conserving therapy patients? Because we all know these are patients who are irradiated, so using implants sometimes are very difficult. And if the oncoplastic surgeons say, well, we cannot do anything in volume displacement, so we have options. As we heard, we have latissimus dorsi flap and the DIEP-flap I would like to tell you about, and lipofilling, as we saw from Professor Schäfflin. So my focus is just to focus on the DIEP-flap surgery after we have bad cosmetic result after breast-conserving therapies, and I would like to show you some cases. So in this patient, she has a carcinoma on the right side, breast-conserving therapy, irradiation, and tried implant reconstruction. And what we do normally in these cases, we do a rest subcutaneous mastectomy and try to fill the skin envelope with the DIEP-flap, the abdominal perforator flap, in order to have a nice breast shape after that surgery. You see here on this side of this breast, and this is after reconstruction, doing a rest mastectomy and deepithelialize the DIEP-flap and putting it underneath the breast tissue. And you see that we can achieve with this very nice symmetrical results in doing that procedure. The next case I would like to present is breast-conserving therapy after breast cancer irradiation, trying of implant reconstruction. And we do the same method as well. We do a rest subcutaneous mastectomy and reconstruct this patient with a DIEP-flap, which is completely deepithelialized, and the breast is getting soft and nicely as compared to the other side. Next case, this is also a breast-conserving therapy. You know, mainly breast-conserving therapy sometimes means that the nipple areolar complex is still in place, but the breast really does look bad. And this patient has irradiation and then trying a latissimus dorsi flap and implant reconstruction with an implant failure. So what you do? Well, we took out the latissimus dorsi flap, did a rest subcutaneous mastectomy to preserve the nipple areolar complex, and deepithelialize a DIEP-flap underneath. And then we will give the patient the projection again, and where the latissimus was, we have now the DIEP-flap, and the whole breast is being remodeled with the autologous tissue from the abdomen. And another case here, and this I would like to show you because you have to plan the procedure. You have to know exactly where the problem is, and you have to evaluate the problem before you do surgery. And this was also a case with breast-conserving therapy irradiation. And what we did is we took out the rest of the breast tissue, and then what we did is reconstructed with the DIEP-flap. But you can see we didn't solve the problem. The patient needed skin on where the scar was, and so we didn't help the patient actually with this procedure because she had this exact same problem like she had before. So just plan the procedure, do whatever is necessary in order to find out what the problem is and what the patient wants, and then do the procedure you want to do. And then what we see when you have a busy service of breast cancer, you see the ulcers coming from the radiation, and the only thing is, in order to treat it, you have to get the ulcer out. Maybe you can make a flap from the side to cover it, but the patient wants a breast. So what we did is we cut the ulcer out, and get the breast tissue underneath the skin as a skin-sparing mastectomy, and then we try to reconstruct the breast to give her the volume. And after this, you see the nice coverage of the ulcer with the DIEP flap. This is also, it's also considered breast-conserving therapy, bilateral, after irradiation and chemotherapy. And obviously the patient can't be happy with this. You see a lot of problems with this. You see on the right side a very thin skin with an implant in. On the left side you see the missing lower pole of the breast tissue. So we have to take care of these patients in order to give them a nice shape, and we're trying hard to get there. So what we did is, on the right side, we took out the implant and reconstructed the breast with autologous tissue. And you always should be aware when the skin is irradiated, you might have some problems. Nowadays, what we do is we do not de-epithelialize the flap. We just see after surgery if the remaining skin is viable, and if you're sure that this skin is viable from her breast, we get her back in the OR and de-epithelialize the flap, because when this skin is getting necrotic, you have a big problem because the flap is already de-epithelialized. So this is after 3 months, it was successful, the skin survived, and then we do a symmetry operation on the left side of this patient. And what we heard today with lipofilling, this is a typical place where you place the scar on the lateral part of the breast, and you take out some volume, and you have some seroma or hematoma, and then you irradiate the breast. And what that means is you have a really bad contraction on the lateral side of the breast, and the nipple is evaluated to the lateral part. So this patient needs volume and skin. And maybe you can treat it with lipofilling. What we did in this case, we added the skin from the DIEP flap and did a rest subcutaneous mastectomy. And you don't have to do anything with the nipple. The nipple will come back to the medial part, and because of the skin, you add to the lateral part of this breast. And you always have to be aware when you do microsurgical reconstruction that you have a plan B, so I call. What do you do when this DIEP flap is failing? So you have to do some other options. So what we did in this case, we did a DIEP flap. When we took a subcutaneous mastectomy, and this DIEP flap fails on this patient. And because we always hook up the vessels to the mammary vessels, we always have the vessels from the latissimus dorsi in place. So what we did is we had to go back, take out the DIEP flaps, and reconstruct this patient with the latissimus from the left side. See this final result on this patient. So what our service is mainly focusing on microsurgical breast reconstruction, and almost 10 years we have over 1,500 DIEP flaps now, and we are very busy and get more and more busy from everywhere because we have to solve the problems we see on a daily basis. And although there are a lot of techniques available with implants and ADMs and lipofilling, there's a huge need of autologous tissue in order to reconstruct these patients. And you have to make sure that this flap is going to be working for the patient, because the patient has several operations already behind her, and she really wants a result which is stable and which is good. So our results are that we have a total flap loss from 1.2%. We're trying to get better on this, but this is not doable for a team which are only doing like 1 or 2 DIEP flaps a month. I think you should do it much more often in order to give the patient a safe surgery. So in conclusion, Breast-conserving therapy is still the gold standard for breast cancer with radiotherapy. And if you have problems, you do either displacement or replacement. And actually, the breast cancer therapy should be an interdisciplinary approach, as we heard earlier. And we have to achieve an oncology safe and good cosmetic result. And this is my team. Thank you very much. Спасибо.